Fantastic. Thank you so much, Dr. Malhameh. I am now delighted to introduce Dr. Zulfiqar Bhutta. Dr. Bhutta was awarded the 2022 John Dirks Canada Gairdner Global Health Award for the development and evaluation of evidence-based interventions in child and maternal health for marginalized populations, focusing on the outcomes for the first 1,000 days of life. He is the Robert Harding Chair in Global Child Health, co-director of Sick Kids Center for Global Child Health, senior scientist at the Hospital for Sick Children, professor in multiple departments at the University of Toronto, founding director of the Center for Excellence in Women and Child Health and Institute for Global Health and Development at the Aga Khan University, South Central Asia, East Africa, United Kingdom. Delighted to turn it over to Professor Bhutta.
Thank you very much, ladies and gentlemen, and thank you for that generous introduction. Let me get this technology sorted out. So I'm going to, first of all, it's been a thrilling morning of science. And what I'm going to share with you this morning is science of a different kind, implementation research at scale, which can influence policy, particularly focusing on some of the highest global burden countries affecting women and children, and also something that relates to global targets and goals. So I have no conflicts of interest to declare beyond a profound interest in the health of women and children across the world. And I'd like to start by first acknowledging that although I'm very happy to be recognized as an individual, in global health, and particularly global public health, individuals count for nothing. Most of the work that we do is done in teams and in collaborations. So I want to start by acknowledging the very large team that I work with in Pakistan and in East Africa. And many of the people that you see here are the real heroes, and several have worked with me for over 2 decades. And I have another similar team, relatively shorter, but now also spanning over a decade here in Toronto, of young graduate students, scientists, and collaborators who have similarly worked on these problems. So I want to take you back over 2 decades ago, when some of us assembled to look at the state of child health across the world. This was around the beginning of the Millennium Development Goals, with not a lot of information, and one of the issues that we tackled was how many children were dying every year under 5 and where. Each one of these dots on this global map represents a cluster of 10,000 deaths. And when we drew this map in Bellagio, we recognized that a lot of this mortality was clustered in sub-Saharan Africa and South Asia. And South Asia appears as a red blob here, largely because of population density. But very little was known beyond the fact that these deaths were happening. One of the first questions was, do we know something about when these deaths were taking place? Because early childhood, 0 to 59 months, is still 5 years. And we set up to ask ourselves a series of questions around how this related to the entire journey of pre-pregnancy, pregnancy, childbirth, and the immediate post-birth period. So if you look at risk of mortality, it's no big surprise that most maternal deaths cluster in and around childbirth, as do some things that we don't talk about, stillbirths. The babies were born dead, early newborn deaths, and then child deaths. And you can well imagine that if you took this continuum, the first 1,000 days, where I've focused a lot of my work over the last 3 decades, represents that area of maximum risk. Pregnancy, first 2 years of life. And if you were to drill down even more on where these deaths were taking place, the very first day of life, which is supposed to be one of the happiest days, in the lives of many mothers and families and parents is also the saddest day in the life of many, because close to around half of all stillbirths, about 30 to 40% of all newborn deaths, and a large proportion of maternal deaths occur in that early 24-hour period. At the time when we looked at this was really not on the global radar screen as a target, but as an indicator that people would follow in countries in terms of addressing interventions. The second big question was, where were these deaths taking place? And to ask that question, we again had to go back to the basics and look at the structure of health systems. And in many places like South Asia, the health systems did consist of brick and mortar facilities, basic health units in villages, in rural areas, mid-level centers, tertiary hospitals, or district referral hospitals. But the quality of care in many of those facilities for particularly serious problems of mothers and children was generally so variable and poor, but when it came to a choice, people voted with their feet. They did one of two things. They either tried to find their way up the upper end of the health system, traveled hundreds of kilometers to a big city, or they stayed where they were. And that's why in survey after survey that my team was involved in South Asia and in East Africa, we found that 50 to 60% of all newborn and infant deaths were in village or rural settings. About a third were occurring in facilities, and a few, sadly, died on their way. Now, if you remember nothing from today, but you remember this infographic from 20 years ago, it will help you understand how some of the strategies that we deployed at that time, through rigorous trials, were focused on addressing this major gap in terms of access and care. And this gap also reflected the challenge that the world faced in terms of the distribution of the health workforce. I was part of the Joint Learning Initiative when we drew this map many, many years ago of how the areas with the highest mortality, sub-Saharan Africa and Asia, were also the regions of the world with the least distribution of qualified health workforce. So the first big challenge that confronted us was beyond just the trickle-down effect of development, which would take Africa 100 years and Asia probably 50 years to reach the levels of development of high-income countries. What could you do in the medium to short term to address this care gap? So could, for example, we deploy through task sharing community health workers to make a difference? And remember, we were interested in task sharing, not task shifting. So to do that, one would look at several models using the same health system that I've just mentioned to you of working directly with families and communities, or through outreach workers, community health workers who are deployed from health facilities, and packages that you could administer in facility care. Now, I've spent the last 25 years or so doing large cluster randomized trials, and I'm going to try and summarize some of this information in a few examples. Each one of these trials, just to give you a sense, takes about 5 to 6 years to implement, to complete from inception to completion, between $5 to $7 million on an average for each cluster randomized trial. These are effectiveness trials in real health systems with real public sector health workers. And more often than not, you wait 7 years and you sometimes get a negative answer. So to the students in the audience and to my own team, I often tell you that I have learned more from the negative trials that I've done. And I believe the world has learned more from the negative trials in terms of how not to do things than you do from the few when you are serendipitously fortunate enough to get results. So the first question was, could we work with public sector, not people that you can hire and fire, but government health workers in these community settings to reduce perinatal mortality? And could you do this through community engagement? And the program that we picked to work with initially was the Lady Health Workers Program of the government of Pakistan, which is largely assembled to work on family planning and primary health care, but did not have a focus on perinatal care or newborn care. And in this initial cluster randomized trial, we looked at a population level in rural Sindh and did two things. One, we created these village committees through mobilization and encouragement, which were basically gatekeepers but men who supported these female health workers and gave them access and allowed them to work with communities. And then the lady health workers did not need a lot of support beyond encouragement to get women together and to do a positive deviance set of examples of how could they make their want better, how could they work towards improving care during pregnancy and during childbirth. We had very little hopes that we would get anything out of this because most of the studies to date had been small-scale efficacy trials. And what we found after 4 years was that some of the results were phenomenal. First of all, very clear differences in the intervention villages versus control villages in terms of antenatal care attendance, care in and around childbirth. People went and bought clean delivery kits. We didn't provide them. They were able to understand the value of a clean birth, looking at even practices that were culturally difficult, like delaying bathing the baby, which would lead to hypothermia or, let's say, an increased risk exposure. And importantly, an impact on hard outcomes. So when I got these first results, as I often tell my students, of an impact on stillbirths, I told the team to go back to the drawing board because that was impossible. We had not put a single obstetrician in the health system. And to have an impact on stillbirth required that you had something at childbirth. For example, increased cesarean sections. And we hadn't done that. So we saw the impact on neonatal mortality. Stillbirths were difficult to imagine. They came back and said, no, the result is there. And then the penny dropped that what had happened at a population level over time, over these 3 years, was a very consistent and a steady increase in care seeking within the same health system that we had not really put any more physicians in. This was one of the first trials at effectiveness level of the role of community health workers, and very rapidly became global policy, with also India adopting this through its ASHA workers. The next big question was, could we train these health workers to do a little more? And one of the big challenges at that time was neonatal infections, and particularly neonatal infections of the kind that related to cord care. To students in the audience, omphalitis is not only very common in about 1/5 of all births, but it can kill, particularly if it is associated with serious pathogens such as Staphylococcus aureus. So the question that we tried to address was, could we do something about this at domiciliary level, at home level, particularly for births that are taking place at home? And in this cluster randomized trial, the design was a factorial design, but very simple, set to answer 2 questions. Could we provide some soap and education to encourage families to wash their hands? And could we include within a birth kit something simple like chlorhexidine to encourage families to clean the cord with and not apply all other kinds of gunk that typically happens in these rural settings? And the district that we chose was Dadu, which is one of the poorest districts of rural Sindh. And as you can see, the intervention isn't rocket science. We provided the chlorhexidine in a small bottle with some instructions to apply it every day till the cord dropped off. And the results were extremely educational. The first important thing to learn was that handing soap and education around hand washing bombed, didn't work. And in hindsight, we could have predicted that because this was a water insecure area. When people barely have water to drink, it is very difficult to convince them to spend about 1 liter of water every day washing your hands, and repeatedly. So despite all the exhortation, that didn't seem to make any difference. But chlorhexidine had a massive impact in terms of both infections and also in terms of neonatal mortality. This 40% reduction almost in neonatal mortality was remarkable and quite extraordinary. And it needed to be confirmed in other contexts and geographies at scale. And that's exactly what happened, that in South Asia, in Bangladesh, and in Nepal, similar studies, some with a slightly different design of not daily application, but single application. And you can see consistently in this Kaplan-Meier curve that you could see very clearly that it had a consistent effect. And this very rapidly became global policy at the World Health Organization in terms of what to do about newborn care in facilities and also in community settings where births were taking place in less hygienic circumstances. In our ambition to do more with community health workers, we also tried to look at another killer, which was pneumonia in young infants, and particularly severe pneumonia, where the only alternative was to send them to a hospital and to provide them hospitalization and potentially intravenous antibiotics. And pneumonia, to many in the audience, is a killer, particularly in young children who are unimmunized. Today, we are dealing with a fortunate situation that globally pneumonia deaths have gone down because of the widespread use of hip vaccine and pneumococcal vaccine. But I'm talking about 20 years ago, when this was really not at scale at that time. And the only recourse was early diagnosis and management. So in this cluster randomized trial with community health workers, that's exactly the question that we asked. Could they recognize severe pneumonia early? Could they treat it? But to do this trial, we had to set up an additional safeguard of somebody making sure that kids did not drop out of the safety net and had an adverse outcome. So our endpoints for the study were more like identification of treatment failure. And in this large cluster randomized trial, you can see that we proved the point that you could train community health workers in recognizing, managing pneumonia, and overall case fatality rates in both arms were less than 0.5%. So I was very happy, at least, that the point had been made. This became global policy transiently for about 3 years before vaccines kicked in. But at the time when it did, it made a huge amount of difference for places which had no access to pneumococcal vaccines and others. But this is all about deaths. And deaths are a sad, hard endpoint. But there is much more to death. And as you saw from the preceding presentation, morbidity and adverse outcomes also relate to things that do not necessarily lead to mortality. So our interest shifted over this period of time to also looking at things beyond mortality. And a large part of my group's work shifted to looking at nutrition. And as some of you might know, one of the biggest global challenges that we have is linear growth retardation. These curves of how children grow across the world tells you how we live in different worlds altogether. These are length for age z-scores, and as you can see, in many regions of the world, the Southeast Asia, which is largely driven by South Asia, and African region, children deviate very quickly after birth. And by 6 months of age, by 24 months of age, a large proportion are stunted, which means that they are below their expected height for age. You can see that in this group of African children. The line that you see in chalk on the wall is what you would expect to be the average height of children at that point in time, looking at global standards. You would never notice in that community that anybody was abnormal or different, because the normal here is what you see. And that's one of the reasons why in many global contexts, governments miss the point that 40, 50% of children under 5 were stunted. The numbers were huge. And even today, as we speak, there are close to around 150 million children worldwide who are stunted under 5 years of age. And most of this occurs within the first 24 months of life. With my friend Chuck Nelson, who identified how important this period is in terms of not just growth, mortality, but also development. And if you look at how many things such as language, sensory motor functions, and higher cognitive functions develop over time, you can see how important this first 1,000 days, the first 2 years of life and the period of pregnancy is in terms of optimizing neurodevelopment. Some of these impacts on these children are not just short-term, around the time when they live. And if you were to look at across the life course, some of these adverse early exposures, particularly in the first year or two of life, can have lifelong consequences, which we are beginning to recognize now. They're not just limited to that period. If COVID has taught us one thing, is that how important the school age period is also in terms of adverse consequences that impact children well into adolescence and adult life. So we didn't know a lot of that at the time when we designed these interventions. The simple question that we wanted to answer was, can you do something about this at scale in population settings? And with my colleague Aisha Zousafzai, we designed a cluster randomized trial to try and answer that question. And this was done with community health workers working in rural Sindh, different area, where we tried to see if you could integrate early child stimulation with early child nutrition, education, and messaging. It took a little bit of time to develop this. The cluster randomized trial, again, large scale, hundreds of children and different villages. And the intervention was based on what was available at that time from UNICEF and others as a stimulation package. This has improved since, but it was basic around interventions that parents can do. We all do intuitively, like singing, talking to the child, eye contact, stimulation. The results were very interesting. We were able to demonstrate a huge impact in terms of developmental outcomes by 2 years of age. This has subsequently been shown to be true at 5 years of age as well. The tools were limited, but using Bailey's, we were able to show that. And we also found that it did very little for nutrition. If you looked at linear growth, despite the fact that these children were stimulated, education by itself in this food insecure population did very little. So the next big question was, could we improve nutrition? But WHO picked this up, and these trials, particularly this cluster randomized trial with community health workers, was the basis for the development of the nurturing care framework by the World Health Organization and UNICEF. And this framework is based on 5 indivisible essential components. And they include health, safety, nutrition, environment, and protection. And these are extremely important in terms of providing children the safety nets and the safe platform on which to layer everything else. In this period of time between the middle of the MDGs and the end of the MDGs, this was an exhilarating period. And both with my team here at Sick Kids and in Pakistan, we were able to influence several large Lancet series based on collation of the evidence, synthesis into practical, easy to implement, understandable packages of interventions that governments could pick up. The Lancet 10, these nutrition interventions that we developed in 2011-12, were taken up by many government planning bodies and bilaterals as the platform for scaling up nutrition interventions. First big question that they asked was, how much difference would it make? And we were able to show that in a large number of countries which had close to around 80-85% of the stunting burden, that these could make a lot of difference, both individually and collectively. We were also able to cost it at that time ourselves in terms of cost per life year saved or DALYs averted. And the World Bank picked it up in terms of developing a costing model. This costed model for the global framework for nutrition asked for $70 billion invested over 10 years, which, if you look at how much we have spent on wars and everything else since, is nothing. This is what would it have taken the world to implement some of these strategies. But because advocacy and science-based synthesis of evidence itself is not enough, tremendous pressure upon us to, okay, walk the talk, show us that it can be done. And it can be done at population level at scale, and it'll make a difference. So even though I had told our team that I was truly not interested in doing a trial around the first 1,000 days interventions because they were all based on solid science, and it made very little sense to go and do it, we were forced to implement this in the field to demonstrate that it can be done, and to do it with government health workers. So in our most recent cluster randomized trial, asking that simple question, do these nutrition interventions in the first 1,000 days make a difference? We've had to do exactly that. And this was done in, again, another district of Sindh. And I showed this particular slide to various audiences to make the point that this was an effectiveness real-life trial. And that's why the coverage of what we got is around 50-60%, which is what you get in real-life setting. In an efficacy trial, we would have got this coverage up to 90% or thereabouts. But because this was people making a choice, whether they took a commodity in pregnancy, whether they took a commodity during breastfeeding, or they implemented something after birth, we were dependent upon what people would do in real life. So compliance, 50 to 60%. Did it make a difference? Made a huge difference from interventions in pregnancy, both in terms of low birth weight, in terms of wasting in the first month of life. We saw a consistent difference in terms of reduction in stunting in these children right up to 24 months of age. And importantly, something that's very resilient to change is a reduction in wasting. Others wanted to see more. A cluster randomized trial is at best at a population level of about 1 million. They wanted this to be at large national level. And to do this, our team at Sick Kids had to do what we call exemplars, is to look at the best performing countries in real-world setting to see how had they improved nutrition. And these exemplar studies that have been published looked at the 5 best performing countries in terms of how nutrition changes, how stunting reduces. And it made a very important observation that in addition to the kind of commodities and nutrition-specific interventions that I've been talking about, that you also needed to invest in contextual interventions to improve women's education, to invest in family planning, to increase women's empowerment, and to reduce poverty. So those conditionalities were just as important as giving people iron folic acid tablets or improving things after birth. And this has now been shown convincingly across a much larger number of countries. This was published in the Lancet last year, and through examples which are at subnational level, that you need a combination of both. So in terms of going forwards, that's the policy imperative of not just restricting interventions in nutrition to the health and nutrition sector, but to go beyond that. So as I close, what does the next decade or two look like? So the first important thing to the students in this audience is, despite the success that we have had in the Millennium Goals, we still have an unfinished agenda of reducing premature or preventable mortality. We just have a wider age band. In the MDGs, we were focused on children under 5. But if you take the extension of children from 0 to 20 years of age to adolescents, we still have close to around 9 million preventable deaths, particularly in children who have been ignored so far, the school-age children and adolescents. So we have a mountain to climb still, beyond the mountain that we have already climbed. The second is that you need to extend the nurturing care framework to beyond the first 5 years of life. So the principles of protection, nurturing, care, safety, optimizing health and nutrition is just as important for school-age children and adolescents as it is for young children. Now, this is something that as parents we know intuitively, but in global policy has just not been the framework that has guided our work. So I'd encourage students in the audience to read the most recent Lancet series that we published earlier on this year on optimizing child health and development, right up to adolescence, that I hope will guide future policy. So let me finish by saying that the Sustainable Development Goals are here. We talked about those yesterday. These are goals that most of us are not going to be able to reach because they finish by 2030. But already we're talking about how can we go beyond the 2030 targets. And my premise to you is that women and children, particularly young children, need to be at the center of the Sustainable Development Goals for us to reach our human capital potential. Thank you very much for your attention.